Hi, I'm Lee Kelso. This is HealthCall Online, the place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Radio Hour, which is now available to stations across the country and nationwide syndication. So think about the last time you went to the doctor. Did your doctor spend more time looking at the computer screen than you? Well, many patients say that's the case. And I can tell you, doctors aren't necessarily happy about that. Electronic medical record systems are all over the country now, and some people say they're taking a toll on the quality of care. Let's learn more about this by jumping out to the University of California at San Francisco and talk to neurosurgeon Dr. Anthony DiGorgio. He recently wrote an article with the headline of Death by 10,000 Clicks. So that really got my attention, Doc. Glad you're here.
Thanks for having me.
You bet. So is that a round number, or is that an actual count of clicks?
No, it's not an actual count of clicks. We did do a study counting the amount of hours our residents were logged in. But yes, sometimes it feels like death by 10,000 clicks.
Yeah, I'll bet that's so. So for all of us patients who don't really know what this is all about, what is an electronic medical record system supposed to do, and how are doctors using them?
Well, so the electronic medical record replaced the old paper charts, right? So when you would see the doctor before the EMRs or EHRs were implemented, the doctor would write notes in a paper chart, store it in a filing cabinet if you're admitted as an inpatient. Similarly, so there's a lot of paper charts, things had to be tracked down. So the electronic medical records were intended to replace paper charts with computers. It had to actually be mandated. It was predated the ACA, the Affordable Care Act, that hospitals had to transition to electronic health records over a period of time. And so now that they are ubiquitous within medical care.
But there are different systems and different configurations. So what your doctor uses may be different than someone else's doctor. What they are all containing, though, is information that is supposedly supposed to help me receive better care. Is that the case?
Well, I think there are a lot of benefits. And so I don't want, our article is very critical of EMR, but I do want to acknowledge there are a lot of benefits and efficiencies that have been gained with EMR. For example, EMRs are very good at collecting and displaying data that used to be pretty disparate back in paper charts. So laboratory results that may be over different labs can now be consolidated in one place. Imaging results for neurosurgeons, that's a very salient issue. We don't have to go hunting down in the radiology department to find those old plastic films that they used to hang up on the wall. Mm-hmm. Those are now collaborated and displayed, and we can track them over time. So it's much easier to collect and display information with EHRs. We have a long way to go because of a lot of technology and privacy concerns. The interoperability and transition between different systems isn't quite where I think people envisioned it when EMRs are first being rolled out. For example, we're one of the few industries that still uses compact discs because in order to transmit images, patients typically have to burn their images on a compact disc, bring them to my office. We upload them to our central server so that we can then have them stored and have a record of them. But then if that patient were to transition their care somewhere else, they would again need to burn those images on a compact disc because we haven't really figured out a good, secure cloud-based storage system. So, but in the aggregate, EMRs are much better for displaying and aggregating information.
Okay,
the downside is, go ahead.
Yeah, I was just going to get you there. So the downside is it's sucking up a lot of time for physicians and nurse practitioners, nurses, everybody, right?
Yes, and part of it is that one of the promise for EMRs was to be more efficient with capturing billing and coding charges, and they've really turned into systems that have specialized in that. So the large hospital systems purchase EMRs based not on their physician or user friendliness, but based on their ability to capture bills and codes and comply with the various other regulations that have come down from CMS regarding Medicare. So the EMRs have really shifted their functionality not towards patient care, not towards end user efficiency, but more towards capturing billing and coding.
So your study took a look at the doctors in training, the residents in your hospital, in your neurosurgery program. And what did you find?
Yeah, so it was pretty interesting. It was spurred on because I was a resident not that long ago, and I remember we had shifted to EMRs, and I really felt like I was tethered and bogged down to the computer whenever I was on call. Really couldn't get away, couldn't spend adequate time with patients, couldn't spend adequate time scrubbing in cases. And I noticed as I became an attending that trend continued. And so we found out that we were able to actually pull the audit logs from our EMR and see when residents were logging on and logging off and when they were actually using the mouse and keyboard and what part of the chart they were in when they were doing that. And so the results were pretty staggering. We looked at their overnight call shift. Our residents take call in-house, which means they're in the hospital from 7 a.m. to 7 a.m. The ACGME, the accrediting agency that tracks resident duty hours, allows for a few extra hours on either end of that for patient continuity tasks. So we actually looked at a 28-hour call period because we wanted to capture all that, and found that they're logged into the computer for about 20 of those hours, and they're actively using the mouse or the keyboard within the EMR for about 9 of those hours. Now, the active time doesn't capture things like looking at images or the residents, prepare lists of patients for the attendings that they do, on Microsoft Word. So it doesn't capture that because that wasn't actually within the EHR, but that 20 hours of logged in time captures that. And I went to the residents and said, these numbers are pretty drastic. Does this make sense? And they said, absolutely. They feel like they're literally pinned down to the computer when they're on call.
And I am reading the comments below your article that was published in MedPage today, and you hit a hot button. There are a lot of clinicians who aren't in love with this process and think it is harming the quality of care. What's your sense of that?
Yeah, I really think it does. And you hear it from physicians, you hear it from patients, right? The patient goes to the doctor and they say, my doctor's facing the computer screen the whole time. They're not looking me in the eye and talking to me. And the reason that is that each patient requires a certain amount of time on the computer to complete patient care. There's a famous study. We're not the first study that's looked at this. There was a pretty famous one a few years back that looked at the ambulatory care setting, so the outpatient care setting, and found that for every hour of face-to-face time, a physician spent 2 hours on the computer. So I think this really is a detriment to care. I think patients and physicians both feel it. Like I said, we're not the first study to look at this. There's been plenty of studies that have shown that increased EMR use is associated with high rates of burnout. It's associated with low physician satisfaction with work, and it's associated with worse patient care.
Yeah, in fact, I saw in the comments beneath your opinion piece a couple of doctors saying this is enough to drive me away, or it did drive me away. So that's pretty significant. So tell me more about what type of information, how much time does it take to generate my notes?
It really depends. There's people that have different levels of comfort with the EMR, and there are some shortcuts that we can find that people will use. But even people that are really facile and good with computers spend a lot of time on the EHR. I've consider myself very computer savvy. I've had a computer since I can remember. I've built my own computers before, but I get incredibly frustrated. So the information that we're putting into the computer, there's our clinical note. And the clinical note, I think, is a little bit easier because I'm a quicker typer than I am at handwriting. So it's nice and easy to put in a clinical note. But the problem comes in that billing and coding requires a lot of extra information in a clinical note that I may not otherwise put there. And so in order to bill for certain levels of physician fees for that note, there has to be a certain amount of information in there that many physicians consider extraneous. And as most of us are hospital employees now, the hospital collects our physician fees. And so they want us to maximize the billing on that. So if we don't maximize our billing, we're going to get emails from administrators saying, hey, why didn't you put this information in there? And then on top of that, the hospital billing is also based on our notes. So in order for the hospital to maximize their billing on the inpatient side, it's done with what's called a DRG system. And the sicker the patients seem on the DRG system, the more the hospital can bill. So again, if we don't use specific words in our notes to denote how sick those patients are, the hospital will email us and say, hey, did you mean to say this in your note, that patient has X condition? Because if so, we can up our billing. And so, in order to prevent ourselves from getting those emails and being tied back down to the computer, physicians will really just overload their note with all the information they can see.
Yeah, there was a quote from one of the commenters beneath your article. It's all about reimbursement, document, document, document. Even if you're trying, or even if you're lying and you've never looked at the patient's ears, nose, or throat, or palpated all their lymph nodes. So, yeah, there are people out there complaining about what they're being asked to do. How much time does this take physicians after their work day? Do they take work home and complete it there?
Yeah, there have been plenty of studies that show that it's what's called pajama time, where physicians will take their work home with them and complete it. My wife is an OBGYN. Routinely, she's brings her laptop home and is finishing her clinic notes at 6, 7, 8 o'clock at night, or waiting until the kids have gone to bed to do them. I take call for a week at a time, so I'm always jumping on the computer to look at new images or finish some of my notes if we've had a really busy day in the OR. And so a lot of this is done at home. There's one study published looking at residents that found that about a third of the general surgery residents, about a third of their time on the EMR was actually done outside of what we consider normal working hours.
Yeah, I saw one person comment that she added up all her time and over $100,000 in personal time was spent keeping up and catching up. Does that make sense to you? Does that sound about right?
That seems like a low ball.
A low ball?
Oh, yeah. I mean, physician time is, I don't want to kind of tout ourselves too much, but physician time is expensive, right? And so for us to be doing these menial documentations, data entry tasks at our hourly rate is probably not an efficient use of resources.
So that has led to more organizations hiring scribes or someone to do this with you. Is that a good idea?
I think scribes are a great stopgap, and there's been some studies showing that scribes will actually pay for themselves because all these things that increase your billable RVUs to the hospital and your DRGs will actually be better captured by scribes who are specifically trained to do that. However, that doesn't fix the underlying problem, is that these regulations exist from a top-down manner and are forced there kind of by CMS in order for these things to be documented, because there is such an incentive structure from Medicare for hospitals and physicians to document that. So yes, scribes are great, but they're just a bandage over the underlying problem.
So what do we do about this? What's the fix, and how's it going to help the patient to resolve this problem?
Yeah, if there's one thing I wouldn't bet against, is innovation, especially disruptive innovation in software. I think that there's a lot of ways that this can get better, and it's going to be both a top-down and bottom-up approach. I think all these regulations that have come from the top, these DRGs, quality metrics, all the things that are adding to this documentation burden, it's been really death by 10,000 clicks, and it's not one regulation that you can undo and fix. So it's going to take a concerted effort to go through these and see which regulations can be scaled back. For example, a lot of the information that used to be documented on notes just at the beginning of this year was scaled back. And so the notes that you have to do as an inpatient provider actually require a lot less information. And so there has been a step in the right direction there. But there's plenty of other regulations. One example I always give is called the appropriate use criteria. Whereas if I order an MRI or CT scan, not only do I have to put all the clicks to get the order in associated with the diagnosis code, but then I have to go through this decision tree tool, and this is mandated by CMS, by the government, to tell me whether or not the condition is really appropriate for the imaging I selected. Because my clinical judgment is obviously not enough. The computer needs to tell me, are you sure you didn't mean to order a CT scan? It's like, no, I didn't. I meant to order the MRI. So just eliminating that, and we look specifically at that. And our residents were spending 10 to 15 minutes of that per day just on that one little tool. So just eliminating that saves 10 minutes there. There's numerous other regulations that eliminating it was 10 minutes here, 10 minutes there, and then you have back to over a while back to normal work-life balance.
One of the complaints I've read is, so you're a hospital guy, you're focused on surgical procedures, primary care physicians. So this really is driving more of these private primary care physicians out of private practice and selling the practice to a big organization because they don't want to have to support the IT and the licensing of these systems. Is that what you're seeing in the real world?
Yeah, I mean, these are expensive systems, right? So a lot of it, and they're very consolidated. So there's a few big vendors that do these EMR systems. They're very expensive. And that lack of interoperability really makes it difficult that if you are a small private practice, you either have to pay to get on a license of the big hospital nearby and take advantage of their economies of scale, or you have to purchase it on your own, which is extraordinary, and then maintain on your own, extraordinarily expensive. And then even if you have the same system, there's still not full interoperability with the hospital down the street on the medical records. And especially if you have your own system, there's not going to be interoperability. So if a patient gets admitted and then comes back to your office, you're not going to have access to all those records right away. They may be imported in PDF form or something like that, but it's not fully interoperable data.
So if I just want to be Marcus Welby and have a small family practice, this is a disincentive.
It is. Absolutely, it is. And in addition to complying with all those quality metrics, and, maximizing your billing, again, hospitals have teams and teams of people that are focused on that. And so they do take advantage of those economies of scale because of all these regulations.
Yeah, I get that. So let's talk about where this goes. If there were two or three things that you would suggest, kind of what's the fix?
I think the big fix, I'm a free market guy, and I think really coming from the bottom up is the way to encourage more competition in the space to get more user-friendly, more interoperable EHRs. So a couple regulations that would lead to that is one, mandating more interoperability. I think that we're not taking more advantage of cloud-based computing and the blockchain for patient data. Patients should own their own data, be able to take it from provider to provider, and have EMRs that seamlessly integrate with that. I have an app on my phone that aggregates all my banking data together into one, seamless app. I don't own that data. But that app does that. So why can't that be done with healthcare data using a blockchain to ensure it's secure? Once you do that, then you get rid of a lot of those barriers to entry. So you have more competition in the space, and you can get more EHRs coming in, competing with one another, and then really allowing the market to let the ones that are the cream of the crop kind of rise to the top. And the other thing would be making it so that the incentive structure doesn't incentivize just large administrators picking out these EHRs, but more EHRs that are user-friendly. So one thing from the bottom up would be more physician-owned hospitals. There's a study showing that hospitals that are owned by physicians actually have more user-friendly EHR and less physician burnout associated with the EHR. Physician-owned hospitals are currently banned under the Affordable Care Act. I think reversing that ban would allow more competition in that space as well.
So let's talk about the burnout factor. I keep reading that we're facing a crisis, that we're going to run into, all of us old guys like me. I'm a boomer hitting those, getting close to retirement age here. My utilization of healthcare is going to increase just at a time when a lot of docs are retiring. Are you seeing that as a big threat?
Yes, absolutely. And there's something that's called the labor productivity curve. If you haven't heard of it, it's released by the Department of Labor Statistics every few years or so, and it measures how many humans it requires to have an output of X in a certain industry. How many people does it take to manufacture cars, et cetera, et cetera. And most industries get more efficient, right? It takes fewer people to farm your food and produce your TVs. Healthcare is the exact opposite. It's taking more and more people to treat the same number of patients over time. So as we get an aging population, and doctors dropping out because of burnout, you're gonna really face a shortage of physicians because you are requiring more and more people to treat the same amount of patients. And part of that is the growth of this administrative state. As I mentioned, all these quality metrics, all these DRGs, all this billing requires more administrators to meet all these metrics. But part of it is that just, physicians are getting torn away from patient care. We're doing more on the computer. And I see it, just for seeing one patient, I spend a lot more time clicking and going through the computer than I do actually treating that patient. I think with an efficient system, I could double or triple the amount of patients that I actually care for rather than just being stuck on a computer filling out checkboxes.
So how do I know if my neurosurgeon, if I'm going in for a procedure, is at the top of their game?
That's tough. So word of mouth is always a good thing. If you know anybody that knows them, if you know anybody in the medical field, I think if you have access to people in the medical field, they'll usually tell you who the good neurosurgeons are. I think neurosurgeons that work at academic centers are usually pretty good. There's certainly excellent private practice neurosurgeons out there. Going back to quality metrics, I wouldn't trust those at all. The quality metrics.
Thank you.
Yeah. So the quality metrics is really more, how you game the system rather than how you are as a surgeon. For example, one of the quality metrics that we get judged on is called our HCAP scores, which is the patient satisfaction score. So, you go to the doctor, you get that survey. After you see the doctor, 90% of people toss the survey out and never fill it out. The ones that do fill it out usually have a chip on their shoulder. And so it's really not representative of you are. There was actually a really interesting study that showed that patients that had higher satisfaction with their doctors actually had shorter lifespans because their doctors may be, just placating them or not giving them the real treatment they need. And so I wouldn't trust your satisfaction scores or your quality metrics. The CMS star ratings are not great. And then just another quick example is the CMS star ratings and quality metrics do tend to punish safety net hospitals and hospitals that care for more disadvantaged patients a bit more. And a lot of it is resource allocation. We can't afford a lot of those administrators to sort of massage those numbers, to email the doctors, to remind them to upcode a lot of their diagnoses to make sure that your quality metrics are better. So I think the star ratings and quality metrics are not a good judge of who's a good neurosurgeon.
That's exactly where I wanted to go for just a second here. So one of the goals of the EHR system was to do some look back analysis and figure out what are we doing right, what are we doing wrong. What I'm hearing from you is we're not really getting all of that benefit.
No, we're not. So, looking at quality metrics, one of the goals was say, which hospitals are performing well, which doctors are performing well, which aren't. But the quality metrics have to be risk adjusted, right? My hospital sees a lot of very sick Medicaid patients. We have a large homeless population. Hospital down the street may see a lot of really well-off patients who do yoga every day, right? So we're treating different populations at baseline. So we have to risk adjust for that. Well, the risk adjustment metrics are actually so complicated and convoluted that you can get a really good return on investment by just learning how to massage your risk adjustment metrics without actually improving your actual outcomes. And a lot of hospitals have figured that out. And there's papers showing that by just investing a little bit in better coders and billers, your revenue can go up by orders of magnitude just by massaging those risk adjustment metrics.
Fascinating look inside a world that all of us on the outside know nothing about. I'm glad you shared this information with us. Dr. Anthony DiGorgio from the University of California, San Francisco. Thanks.
Thank you very much. It's been a pleasure.